Hello and welcome to an introduction to the Penn Medicine CHIME tool. CHIME was created in partnership with the Penn Medicine Predictive Healthcare team, Penn School of Medicine and Biostat faculty, and the CodeForPhilly, a volunteer open source community in Philadelphia. CHIME is a tool designed to assist hospitals and public health officials with hospital capacity planning. In this video, we're going to walk through how to use CHIME, how to adapt its inputs to your local hospital and or region, and how to interpret and evaluate the demand projections produced by CHIME. CHIME inputs are on the left-hand panel. If you're using a mobile device, these are hidden by default. It's organized into four primary areas. There's the hospital parameters or regional parameters, spread and contact parameters within your region, and then the severity parameters. These are the values that translate the spread of the infection into capacity and impact to your region and the health system defined by acuity level. Finally, the display parameters. There's the output panel that gives a verbal summary of the scenario and then a graphical representation of admissions by acuity level, both total hospitalized patients, patients that will be admitted and requiring a critical care bed, and then patients that are admitted and require ventilation. You can expand that graphical form into table to look at data by week or by daily count. You can also export that data into a CSV file for later analysis. That data feeds the census or bed capacity demand based on the admissions. There's the equivalent representation of total beds needed within the hospital, which includes non-ICU, non-vented, as well as vented and ICU patients. Then the total number of critical care beds and the total number of vents needed, again with a summary of peak information. And again, you can expand this in tabular form to look at it as weekly snapshots, and also expand to look at the daily values. And you can also export that data into CSV file as well. Okay, we're going to walk through the parameters driven out by a scenario from our downtown hospitals. We have three downtown hospitals that serve a 4-county region. If we take those 4 counties, look up U.S. Census, we'll find that there's about 3.6 million people that our health system serves in those counties. One way that you can then kind of scale this scenario down to what you think will impact your health system is to use this market share percent. One way to get a decent estimate on that market share is to take a look at the total number of hospital beds in that region that you're looking at, or in our case, 4 regions. Go to the State Department of Health site to look at total number of beds, get that number, look at total number of beds within your health system, and take that ratio. I'm just going to show an example of the PA Department of Health site where you can grab those values, and in this case it's got a nice way to submit a request and pull down a spreadsheet. So as I said, for us we're going to enter 15%, and then today I believe we're around 150 or so patients, COVID patients, that are admitted within our health system. So with these settings, you can define your primary scenario, and you've scaled the scenario to the health system of interest. And one thing you'll notice in the output panel is that the text summary changes as you enter in different values. And the hospitalized patients is kind of the baseline or standard that CHIME uses to estimate the total number of patients that are infected in the region. And of course, without any good surveillance through testing, we don't really know what that number is. So we're taking these estimates of total number of hospitalized patients of all infected people and your market share, looking at the hospitalized patients to back into that total infected patient number. One quick note, this current hospitalization number is in reference to the current date. And on CHIME, at the very bottom, this default date is supposed to update to the current day, and in this case it did not, so I'm just going to update it to the current day. Scroll back up to get my total regional settings, and now I have a consistent set of numbers. So on to the spread and contact parameters. CHIME provides two ways to fit the SIR curve to your observed data that you entered. So today's date with current hospitalization. What you can do is enter in doubling time of, in this case there's a doubling time of 4. Just update that to 5, and what you can see over in the output panel is if the doubling time was 5, and that would imply an R naught of 3, meaning any infectious person is going to infect a total of 3 susceptible people during their infectious period. This 3 value is, might be more in line with some recent publications, and we're just going to keep it at 5. There's another way to do a fit within CHIME. You can actually say, you know what, I know the date of my first hospitalization within Penn, that was March 16. And of course now I've given CHIME 2 data points. That's March 16 with a initial hospitalization of 1, and then April 5th with a hospitalization of 155. And so now CHIME will use a least square error fit to those 2 points, and then back into what it thinks is the current doubling time of 3 days. So in the process of this fit, CHIME is actually backcasting its estimated admissions over time. So you can see this gray line here. Try to highlight this April, let's see, 3rd, 4th, getting close there. And it's actually projecting back in time what it thinks the admissions would have been. And so of course we are entering the census. So let me just expand this table so we can take a closer look. And what you can see is we have day 0, which is April 5th. We entered 155 patients, and CHIME is doing its best just through a least squares error fit to match that point, as well as expand out here in the daily count. The March 16 of 1 admission, you can see you can't hit a perfect fit, but in doing its best, it's estimating 102 patient census at April 5th, and first admission on March 19th. Social distancing parameter, this is the percent reduction in social contact going forward from current date. For Penn Medicine, we have worked out some guidelines for ourselves on different policies. School closings, we think are 5% reduction in social contact, closing non-essential business, 9%, doing all those things, as well as stay-at-home orders, we think are between around 35% reduction in social contact. We have a blog post on this. You can explore that, our process, a little bit more. What you may notice is that as I was updating those values, again, the output panel was updating its going forward impact on the doubling rate and rate of transmission. If we have a social reduction of 35%, then we take an R naught, a pretty aggressive R naught of 4.6, and modifies that to 3.2. I'm going to swing back to unselecting known first date, update this value to 5 doubling time, and continue on with social distancing of 35% reduction. If we then move over to the output panel, looking at the graph of admissions per day, you can see moving forward from current day, April 5th here, this gray line, there's actually a shift in the curve, and that's the impact or effect of the social distancing going forward. Change this value to 40. Again, you can see this flatten out more and more. So on to severity parameters. That's the impact to people infected by by COVID-19. This is often where we get a little confusion on what we mean by parameters, and I think that's primarily because of the variability in the way people are reporting severity of illness, asymptomatic patients, mild, severe. Again, since our simulation runs on all individuals infected, over in this output panel, you can see this number. We have to drive out what we think the capacity impacts in the health system will be off of that number. So we estimate that all patients that are infected, 2.5% of them will be hospitalized. And we continue that down through percent of patients that will require critical care and percent of patients that will require a ventilator. These parameters are obviously related. So 2.5% of all patients infected will be in the hospital. This would then also include patients that are vented and in critical care. And so the ICU percent can be backed into this total infected as a proportion of total hospitalized and as well as vented. This works out to be 0.75 is about 30% of 2.5%, and 0.5 is about 60 or so percent of 0.75. By setting these values, these proportions of patients of total infection that have different levels of acuity entering into the health system, this is directly impacting the size of the curve. So as a scaling factor, if I double the rate of hospitalizations, I'm going to double the peak size, and so on through those values. Infectious days is the number any single person will be infectious. This number has a direct impact on R naught, and then of course the rate of spread. So as someone might be infectious for say 10 days, this was going to have a direct effect on the number of people a person can infect while they've been infectious, of course. So as you change that number, moving it back up to 14, you're going to see R naught go back up to 3. If you bring it back down to 10, the number of people a single person would infect would reduce down to about 2.5. Finally, we get into the length of stay of COVID patients in the hospital system. This is another area that's created a little confusion within the CHIME tool, partly because of just the dependence of these different acuity levels. Average hospital length of stay is meant to indicate for all COVID patients what is the average length of stay, and this is the value that takes the number of admissions and translates that into admissions and discharges, which this curve accounts for. So just again, hospital length of stay, this includes patients that are just in the ward that were in critical care and not vented, or patients that were vented and then heading off to critical care and then med surge. Average days in the ICU, this is for any patient that spent time in the ICU. How many days did they spend in the ICU? And then average days on vent. These default values that we have came from some analysis of similar diagnosed patients within our own health system. There are some more aggressive length of stay numbers out there, but just to keep in mind that these numbers are dependent on one another, given the different ratio of acuities that you see in the hospital. The display parameters, well, at least I use them most often when I'm creating reports to be shared out, and I want to lock in the axes for comparison. The value that is most useful in that case is, of course, the y-axis. So you can see the particular difference when you're changing doubling time from say 5 to 3. In this case, I'm kind of breaking the selected axis point. So I'll put in 5,000, and then of course then to go back to doubling time of 5, you can see the distinct difference of those two scenarios. Well, everyone, I just want to thank you for taking time to listen to this introduction. If you want to seek out more information, we have a great documentation out on different parameters, how to interpret results, and then different users and use cases. You can also reach out to us directly on the CodeForPhilly Slack channel. There's a CHIME help tab in there, or you can just jump into the conversation on a few other topics such as analysis. We have our predictive healthcare team site where we have listed out there our different blog roles. As we discover new things, we'll put it out there for you. And then should expect some future videos, particularly if you find this interesting. Please let us know. We're looking at describing out different actual use cases, how we bound our scenarios to report back to decision makers, and as well as just other insights into these parameters. Thank you.